So we're still in Chapter 9. We're going to talk about heart conditions. One thing to remember is the heart has to receive a constant supply of oxygen or it begins to die very quickly. So the heart's going to make sure that it's proficiently oxygenated itself first and foremost, and then the rest of the body. The heart receives its oxygen through what's called the coronary arteries. And the coronary arteries they come through a little leaflet right from the aorta. So you can imagine right when that blood is leaving the heart on the left side, the oxygen-rich blood going to all parts of the body, before it really ever leaves the heart, it goes to the heart. It goes through the heart through these coronary arteries. There's two main coronary arteries, the right and the left. The left is so large, left side of the heart is a little bit bigger, that the left side divides into two so it can cover the anterior and then the posterior walls of the heart. Well, some people have a predisposition for it. There are risk factors like the male gender, the more we age, or if your parents had heart disease, those are risk factors we can't change. But for the most part, heart disease is attributed to risk factors that we can change, like smoking and a diet that's heavy in saturated fats, lack of exercise, stress, not taking care of our blood pressure, not taking care of our blood sugar. All these contribute to a disease process called atherosclerosis. And atherosclerosis is a narrowing of the arteries that feed the heart muscle, the coronary arteries. So progressive atherosclerosis can cause this condition called angina. Angina is that passage gets so narrow that the flow of blood that's needed for the heart can't be met. And that oxygen is not going to the heart, and the heart starts to have pain. But it's a temporary condition. Heart attack, though, is a complete occlusion. It's not temporary, and it doesn't go away, and it can lead to cardiac arrest, or, check this out, like half the people who have heart attacks, their first sign or symptom is cardiac arrest. Their first sign or symptom, that's it. Their heart experiences a clot, and that clot deprives the oxygen of going to that target tissue, the muscle of the heart, and the heart responds by starting to quiver or fibrillate. We learned that term as ventricular fibrillation. And a lot of these happen at rest. People think, oh, they're out working hard and that's why they had a heart attack. Most cardiac events actually happen at night when people are sleeping. So looking at atherosclerosis, you can see this is called the lumen, L-U-M-E-N, of the artery. And it's nice and big and nice and clear. That top left one looks great. That, belongs to somebody that's very healthy. Well, as this plaque starts to stick, there's antioxidants and things in your body that keep the cholesterol going through the system. Like kids need to have cholesterol, but older people need to minimize that cholesterol because we don't have enough protective factors inside the body to keep that from sticking. And that cholesterol and that plaque becomes very sticky. And as that fatty material gets deposited on the vessel wall, you can see that the progression is that it makes that opening a lot smaller. So less blood can flow through there. It's going to increase blood pressure. The heart has to pump against more resistance because it's smaller. But think of it like this. Atherosclerosis isn't something that happens at like age 40. And then by age 60, we have this, right there on the bottom right, that occlusion through there. Atherosclerosis is like a pothole. If you're driving down the road one day and the road's fine, and the next day there's like a little pothole, come back 2 or 3 days later, and what does it look like? It's really big. So once that little tear in the artery wall starts accumulating that fatty deposit, it starts clumping very quickly. So it's a quick accumulation that's going to lead to that. Well, what eventually happens is anytime that you have turbulent blood flow through something, it's going to cause part of it to rupture and break off, and then the platelets, part of the blood, will start clumping in that area to produce a blood clot. So when somebody goes to the hospital with a heart attack, there's not much that they're going to be able to do in the first few minutes for the fatty deposit, that atherosclerosis that you put there or the patient put there. But there's a lot they can do for that little blood clot on the bottom right, the little thing in red in the middle, and they can actually dissolve that blood clot and get the flow going through. We call that reperfusion. So when somebody has a cardiac event, it usually produces chest pain, and that chest pain is instant. And it's caused by an inadequate flow of blood, and without that adequate flow of blood, they have inadequate flow of oxygen to that heart muscle. And they often describe that as a pressure or heaviness. It may radiate into the arm, up into the jaw or the neck, maybe sitting down low in like what we call the epigastric area where the stomach is, right below the center of the chest. And they say, oh, it must have been something I ate. Until they start thinking, well, I'm kind of also short of breath and a little sweaty and scared. I mean, these people will actually tell you, I had the sense that I was going to die. And we call that the impending doom. So ask if the patient's already being treated for a heart condition, because they may have a medication like nitroglycerin. They may have a plan of action. Have them stay at rest. Remember that if they walk, they're walking on that injured heart, so we don't want to see that happen. Check their blood pressure. We want to make sure that the top number, the systolic number of a blood pressure, is at least 100 before they take their own nitroglycerin. So we can't give them nitroglycerin. All we can do is allow them to take their own, what they would have done prior to calling 911 anyway. It's just always a good idea to check the blood pressure. Make sure they're sitting down, not standing up. It can cause them to faint. So they can take up to 3 doses of nitroglycerin, and they're usually told that, take a couple of doses, and if you still have pain, call 911. So they kind of self-remedy this a lot. They know what they did. Oh, and I know I shouldn't have been out there. I was cutting wood, and I was stacking firewood, or I was washing my car, and my chest got a little tight, and I rested, and it went away. Well, that's angina. This is what we call stable angina. They expected that. If it doesn't go away, though, that's when they call 911 because they think they're having a heart attack. So it results when at least one of the coronary arteries is completely blocked. You can see the clot sitting right there. That means that all the blood flow past that clot doesn't happen. That's it. And the longer that area is deprived of oxygen and the more damage there is, the more long-term effects that's going to happen from there. 2 main causes: severe atherosclerosis, where it all just closes up right there, and more commonly a blood clot. So they have the atherosclerosis, but they also have a blood clot that forms or lodges in that area. So signs that you're looking for: the patient suffers immediate and severe chest pain for more than a few minutes. That's a big one. And they're going to describe that pain as pressure. So I often don't like to say, are you having chest pain? I'll say, do you have any chest discomfort? And then that includes pain and pressure. And they say, yes, I'm having pressure. Ask them if it's radiating, and if so, where? Because that's going to tell a lot of, is this cardiac in origin? Or is it, I've got pain to the left side of my chest and no, it doesn't radiate. Well, the left side of your chest sounds like a pulmonary thing, or a pull muscle maybe. So maybe not chest pain from a heart attack. Think about associated signs and symptoms. Are they short of breath? Do they actually feel weak? Or do they sweat profusely? It's cool in the room and they're just so wet. Nauseated. They may even vomit. These are all signs associated with this. So if that block area is in a large space, it's blocking a lot of part of the heart, or it's a critical part of the heart may stop completely. It may go right into ventricular fibrillation. And when they have that cessation of heartbeat, we call it cardiac arrest. So place them on the ground in a supine position. We say on the ground because it's got a firm surface, whereas like staying in bed does not. And start compressions. If you're by yourself, you're going to do compressions only, and hopefully help's not too far out. If you have a radio or a phone, you call for backup and advise them, hey, I was talking to the patient and he went unresponsive. What's the ETA on the ambulance? So get that extra help coming. Get family members if they can help you somehow, or whatever you need to do, because if they're in cardiac arrest, what they need is definitive care, which is at AED. If the patient's not in arrest, but they know they're having a heart attack, and they know this is what their brother died from at the same age, they're scared. So talk to them, relieve this anxiety. I'm here with you. Let me get your blood pressure. Have you taken any nitro if they had it? Something else you may be asked to give them is aspirin. In the first few minutes of a heart attack, aspirin is one of the best drugs that they can take, but there's also risk factors associated in giving this. If they're allergic to it, they can't take it. If they have any bleeds in their body, they had a gastrointestinal bleed or a stroke that was a bleed, they can't have aspirin. So we have to make sure that they're a candidate for this. Let them rest and relax and leave them, alone as much as possible as far as making them move or whatever. Let them assume the most comfortable position. It may be sitting, it may be laying down. If you have oxygen, make that readily available to them. And again, that chewable aspirin. And make sure it's chewable. The whole idea behind like baby aspirin and chewable aspirin is coated, or what they call enteric aspirin. You swallow it and it doesn't get absorbed until it hits the intestine. Whereas if you've ever chewed an orange-flavored baby aspirin, your mouth just salivates like a starburst. And it starts getting absorbed in the cheeks, in the buccal part of the mouth, and it goes to work a lot faster. So always keep in the back of your mind, if I need to start CPR, I need to think about where I'm going to move this patient to, and if an AED is available. So heart attack can be scary, and it should be. You have to remain calm, though. You have to be the calm among the chaos that says, we're here, we're going to do whatever we need to do to make sure that this patient, that the patient's conditions are communicated with the receiving staff. If you're in a remote area, don't be afraid to fly these out. Don't be afraid to get them to definitive care a lot faster. And by that I mean a hospital that has interventional cardiology that isn't going to just look at them and say, well, let's ship them out. Let's get them someplace that we can have that blood clot removed and reperfusion flowing to that part of the heart. Because time is muscle. The longer the area of the heart is deprived of oxygen, the more long-term effects that they're going to have. I want to add a couple of slides in here on congestive heart failure. This is also in your book. So somebody that had a heart attack in previous years, one of the complications, should they survive that heart attack, is that the heart will actually fail. And usually we think of the heart as a two-sided pump, the right side and the left side. Well, the left side of the heart pumps harder, so it usually fails first. And the right side of the heart pumps blood into the lungs, and the left side of the heart pumps blood into the body. So if the left side of the heart fails, then that right side pumps blood into the lungs, and it stays there. Not all of it gets emptied out, and that's what we call congestive heart failure. They end up with this condition called pulmonary edema, where you can actually hear the fluid inside their lungs, and as well as dependent parts. So if they're sitting in a recliner or something, a lot of times you see, or a chair, you see swollen ankles. And the thing about this is that you push in with your finger for a few seconds, and you take your finger away, and you still see a pit. You still see the indention from your finger. We call that pitting edema, and that's a very common sign of congestive heart failure. So these people live in heart failure all the time, and they're never going to get better unless they have a heart transplant. But they have times that the problem gets worse, and usually it's associated with maybe salt intake, or not having or overload of fluid into their body, or just progressive heart failure. So breathing difficulty is going to be the major symptom. You're going to get a call, this person can't breathe, and they really can't. And these people have to be sitting upright. They don't get to lay down. They lay down and they drown in their own fluid. So they're struggling to breathe. They have rapid, shallow breathing. You can hear the respirations, noisy respirations, of crackles, even without a stethoscope in severe cases. But we want to listen to lung sounds with our stethoscope. Oftentimes their neck veins are engorged, again, the blood not being able to flow into the heart. And they're very anxious, they usually are. So sit them up. If you can, keep their legs down to drain some of that fluid back into the lower parts of the body. That's just kind of old school, but it really does work. And they get a lot of oxygen. If you have the ability to do what we call continuous positive airway pressure, or CPAP, CPAP's a great tool. We've kept a lot of CHFers off the ventilators because of that. We put CPAP on them right away, and that that increases the surface tension in the alveoli. And what that does is it allows for more oxygen exchange. Really helps them out. CPAP is great. It's kind of like riding in a Jeep, those kind with the windshields that lay down, and driving down the road, that air just being forced on you. Why do you think dogs, in the back of a truck or hang their head out of a car window? Why do you think they do that? It feels good. It increases surface tension, so it makes it easier for you to breathe. Even little kids, they'll go stand in front of a fan and put their face there, and they have that forced air at them. It makes them feel good. So CPAP is a great thing. And make sure that you call for backup and get that help on the way. Congestive heart failure needs to be transported as quickly as possible, because they're telling you I can't breathe, and it's such a terrible thing to have. I'm going to go ahead and continue on with our respiratory part of this. There's just a few slides, and this will kind of make sense following this, because it's kind of cardiopulmonary, but not of different reasons people can have shortness of breath or difficulty breathing. It's usually associated with a heart or a lung disease. So we talked about heart-related problems like angina and heart attack and congestive heart failure. But let's look at some of the pulmonary diseases like COPD. And COPD includes emphysema and chronic bronchitis. I'll explain those in a little bit. Pneumonia and asthma. So we look at asthma. We'll probably look at that here pretty quick. So when somebody has difficulty breathing, make sure their airway's not obstructed, that they don't have a foreign object in there. They didn't choke on a hot dog or a peanut or something like that. In that case, you want to do abdominal thrust and relieve that obstruction in there. Look at the rate and depth and listen to them. Are they making noises? If they have gurgling respirations, we want to suction that out. If they have snoring respirations, I want to reposition the airway, because the tongue has fallen back and caused a partial airway obstruction. Loosen tight clothing, put them in a comfortable position, reassure them, and oxygen if it's available. Oxygen's a great drug. Not only is it going to increase the amount of oxygen in their system, it kind of works like a placebo. I've seen it, we put nasal cannula on somebody at 2 liters per minute. That increases their oxygen level to probably like 28%, not a whole lot. But we tell them, hey, I'm going to put some oxygen on you. It's going to make you feel better. So it's got that placebo effect. They believe me, and it does. Oh, I feel a lot better with the oxygen. It just does. So asthma. People that have asthma all the time. Something triggers it. And that trigger can be something they're allergic to. It can be an emotional, stressful event. Exercise can be a respiratory infection. It can be a number of different things that triggers it. But what it is a spasm of the air passage that gets associated with excessive mucus production and a little bit of swelling of the respiratory passageways. So that combination causes air trapping. The air can go in, but it can't come out. So you'll actually see people look like their chest is bigger, and they're like, hey. They're really forcing that air out, and you can hear that expiratory wheezing, oftentimes without a stethoscope. So asthma does kill people. And when we're listening to that wheezing sound, as terrible as it sounds, there's a worse sound, and that's nothing. When you go to listen to a chest with a stethoscope and you don't hear anything, we call that a silent chest. Silent chest is a deadly chest. So those people need rapid ALS intervention if they have a not moving much air at all. So the fact that you hear wheezing, even though it sounds bad, it's still a lot better than not hearing that. A lot of people with asthma will carry their own inhalers. EMS will have a nebulizer, and both of these are bronchodilators. They're going to make the passageways to the lungs larger to buy them some time until they can get to the hospital and get some steroids on board and truly take care of that. One thing, though, if you do give an asthmatic oxygen, make sure you humidify it. Make sure you hook up a humidifier to it, because that dry air from the oxygen tank can actually produce more mucus. So here's our slide on chronic obstructive pulmonary disease. These are your long-term smokers or people that have lung diseases like farmer's lung or black lung. And even though they're both COPD, they're kind of either end of the spectrum. People that have chronic bronchitis live 8 to 9 to 10 months a year with no problem. Then 2 to 3 months every year, usually in the winter, they have excessive mucus production. So these are the ones who wake up every morning You can hear that gravelly cough and thick mucus sputum. They cough it up, they spit it out. They're usually overweight and they're usually a little bit cyanotic, so they get the nickname of being a blue bloater. Whereas the emphysemics, their problem, and they have this year round, they have loss of elasticity to the lung tissue, to the alveoli, to the pleura that lines the lung. Everything is loss of elasticity, so they have to work harder to breathe all the time. And they're usually pretty small, thin. You can count their ribs, emaciated, but stay nice and pink. So we call them the pink puffer from the way that they purse their lips to breathe. But both of these live now what we call the hypoxic drive. So we have to be careful to not give them too much oxygen because they get real dependent on that. People with COPD, when they go in the hospital, they have to really look at their arterial blood gases. They'll draw those a lot to see what their true level of oxygenation is and titrate the oxygen for the effect. But if they give them too much, the body gets used to it, and then it'll tell the brain, hey, we don't have to breathe for 2 days. And they don't. They stop breathing. And then we have to wean them off of the ventilator and wean them off of oxygen. So this can kind of be a catch-22. If somebody has COPD and they need oxygen, by all means give it to them. Just know you're going to be ventilating them before you get to the hospital. You're going to be bag masking them before you get to the hospital. But if they've had a little fender bender and they're on 2 liters of their own portable oxygen, keep them on the 2 liters of oxygen. That's all they need. You don't have to up that. So kind of think about that. So that's going to wrap up our cardiac and our pulmonary portion of this, and so we can finish up with a little bit more on, I know it's altered mental status again, but it'll tie in, you'll see. Now we're going to wrap this up right here.